So if there are no further questions, I think what we're going to do sort of ad hoc, ad lib, whatever, is invite both panels of speakers to sort of join us. We don't have enough chairs up there, but there are some interesting issues that overlap the two sessions. The discussion got cut short quite a bit this morning, and wonder if I don't know if everyone's here, but if the group from this morning is here, come on up to the front as well, and we've got all this talent. We want to take advantage of it. I'm going to let you start out with the question.
Mark has been kind enough to let me start out with a question, and it's one that sort of branches between several of the presentations this morning. I was wondering to what extent any of the people conducting the studies that have been referenced today know that there might be overlap between their study populations, and to frame that same question in a slightly different way, to what extent anyone might see chances for synergies between these studies in analyzing information collected among studies towards getting a better understanding of some of the outcomes that were measured in multiple studies. Dr. Morris,
I have an
please
easy answer. So, I mean, there are groups of patients that we've looked at both prospectively and retrospectively that if they don't retire and continue their care within the military system, then I don't see them anymore. So obviously, trying to not track down, but find patients or individuals and continue to track them through the VA system or even through civilian health care and looking at those outcomes of people we've defined who have developed disease while on active duty is difficult to say the least, and trying to synergize. If I have a group of patients, I can give it to all my VA colleagues and say, what are you seeing in your system, and we can put something together. So that has not happened to date. So from what Mike is doing at the risk, he's looking at VA patients. I'm looking at DoD patients, and we're not overlapping in terms of what we're doing in those type of studies. It's a little bit different group, but the same.
Well, to give an example, is it possible that there are people who are both part of the Millennium Cohort study and who have also responded to the Airborne Hazards and Open Burn Pit registry?
Sure,
Do we know whether there's any overlap between those populations?
Currently, we haven't looked at overlap between the Millennium Cohort and the Airborne Hazards Burn Pit Registry, but that's something we can certainly look into with our current data use agreement to at least exchange identifiers between those two populations. One other opportunity for where there is synergy between studies that I do want to point out is between Millennium Cohort and MVP. We do know from a current actually co-enrollment effort that there are now 8,000 Millennium Cohort participants who are enrolled in MVP, and so have I believe would have provided, in addition to completing the survey, would have provided the whole blood sample for MVP as well.
And when you say MVP, that is the Million?
The Million Veteran Program.
Yes.
David, I just want to make a comment about your question. So for the B-Brain Consortium, we were asked from DoD to actually see if we could set up some kind of a global universal ID for our participants, because we're actually sharing from other studies as well. And there was a question about that. You know, how would you know if they participated in other studies? So we've actually been looking into that, and there are some that that we are thinking about utilizing. One is from NIMH, and it's basically you put in information about the participant or the veteran, and it's unique identifiers, and it actually spits out a unique number. And it's a very simple thing to do, and then you don't have to keep these personal identifiers even outside of the government or VA. But it's a really good way of tracking by a unique code these participants, and then you can look at them for all your different studies, and it can be done after the fact. So for any of these studies, you could do it now, and you'd have this unique identifier.
Just one other comment on that is that you'll have another unique opportunity, because burn pits have been going on for so long, before 1991. You have veterans from different cohorts, different eras that have that many more years of life post-exposure to evaluate. And so the most important thing I think we can all do is make sure that we've consented to reconsent, so that we can go back with common platforms and instruments and ask the questions that need to be asked pertaining to this type of thing. I think that's really important. And again, this sharing the complex data set so that someone like you can jump in there and really get the guts of the metabolomic proteome. Now, everything else that's being done on these samples from these veterans from different eras. Often in our calls for proposals, we're very limited to a single cohort. Often the money is very political. The Gulf War vets went to Congress and said, we want money. They get money. It's the Gulf War. And good, that's great. The next, the burn pit guys went this year. They got quite a bit of CDRMP success. So that's different eras, different cohorts, and sometimes you're actually not allowed to compare them under the way the RFAs are written. So being able to think about this, the bigger picture of this, the health span consequences of these environmental exposures to military service, I think that's a greater way to grab it all.
So I'm going to switch gears just a little bit. Dr. Blackwell, the findings from your group and the publication, I think it was in the New England Journal, if I recall correctly, was sort of got a lot of attention in terms of a specific disease or injury related to service. I wonder, after that initial report, do you continue to see new cases? Is this something that was a relatively acute observation? And how many cases is your understanding that are actually out there? I mean, it was a very small number given the number of folks who served. What's your sense of this as a specific consequence of military service?
So thank you. That's an interesting question that I'm not sure I have a great answer for, but I'll try my best. In addition to working at Vanderbilt, I actually see patients at the Nashville VA, and we continue to see patients that are referred to see us in pulmonary clinic with unexplained dyspnea with the same type characteristics as these folks that we actually evaluated over at the Vanderbilt University side. I don't know, I mean, this is anecdotal because it's at one center, but we still see patients that are referred to us that are like this. We recently, and I think this might be a different topic for discussion, have gone to doing cryobiopsies when we run out of options for diagnosis. Otherwise, we've done a dozen or so of those. There are definitely some issues with interpreting the pathology there. I think this has not gone away, but I think going back to the prior question, I think there's an opportunity through the VA system in talking to people at Michigan and Birmingham and the Jackson, Mississippi VA, it's clear that all of these centers, and I'm sure there are many others, have patients in their pulmonary clinics who have unexplained dyspnea, and they've had varying degrees of workup, and we have no coordinated longitudinal information. We have started a small cohort at our VA to look at serial pulmonary function testing, but my sense is that this is at least the severe form that gets you to the point that someone does a lung biopsy and identifies something like constrictive bronchiolitis. I think this is a relatively small number. I would say about half of the people that we get referred with dyspnea have a more classic airways disease. Asthma is, reasonably common in this group that we see too. But, around half of them still don't have a diagnosis, and we see, a few a month that are still referred to us.
So let me ask the same question of Dr. Garshik, who, when I remember when he was young, used to see patients and still may see a few. But do you see this in Boston? Have you made that diagnosis?
Well,
And if so, how
well, I think it may be a matter of referral pattern. I mean, we've seen airway disease, asthma. So with person with unexplained dyspnea, whether it has normal findings otherwise, we would tend to follow them clinically and see if something develops. And I think we could learn a lot by getting some follow-up on what the original biopsy series showed. What's the long-term implications of what was found in the airway, and also having peer review of the airway findings to try to correlate those findings with the clinical outcomes.
Let me ask you a different way. How many patients have you actually sent to biopsy for unexplained dyspnea? I mean, do you have this? I'm sure you have obviously some patients with that, but have you seen bronchiolitis in your cohorts?
Well, I think, and it may be pattern referral. I mean, Boston, there aren't really military bases in Boston, or, where you would draw that up. I don't know where the referral population. We have really not. But Boston might be a fair comparison. And now I've heard of people otherwise getting biopsied for unexplained dyspnea, clearly, with some abnormalities to go after on a CAT scan. But I think that's the clinical elephant in the room as to what stage you actually would do a biopsy on something that may be kind of ill-defined. I think the classic bronchiolitis that's progressive, severe dyspnea, with a lot of symptoms, I mean, that's a different story than somebody they can't exercise to a modest amount. I mean, I don't want to sound like I don't want to sound calloused about that at all. I know that's a problem, but I think that is the issue, the extent of that type of invasive biopsy in a patient who doesn't appear to have any other abnormality, and that's a matter of opinion. So I know an observation was made that should be better understood.
I want to same issue, constrictive bronchiolitis, and this is probably the only opportunity I'll get a chance to have something, addressed, and it has to do with this. When the New England Journal paper came out, we were shocked and depressed at the same time, right? And the depression was based on the fact that you have people with dyspnea, you can study the heck out of them, but you still don't have an answer, and they have to go to biopsy to get an answer, which was just mind-boggling. And then we hear, well, maybe because these were clinical specimens, they weren't fixed through the bronchi, that there was a lot of artifact, and that maybe a lot of what they were seeing and calling constrictive bronchiolitis, in fact, was artifactual. So my depression lessened. I was thinking, gee, maybe it's not such a big deal. But I'd like to get some clarity on that as to what you think, whether that original observation still stands the test of time, whether in fact a lot of it was artifactual based on the fixing technique, or not.
What I'll say about that is that I think with any sort of clinical biopsy of the lung, it's impossible on any individual sample to rule out artifact once you obtain a block that you didn't manage the collection and do the analysis, and then you know some years later maybe do the analysis. So I'll give you that there's some potential for artifact here, but I think we've shown clearly that there are histologic abnormalities in the airways of these patients that have been given this diagnosis that are consistent with the kind of damage that that you might expect here. So I didn't show you that these airways have epithelial damage, they have loss of ciliated cells, they have increased collagen, and there's smooth muscle hypertrophy. So I think how you give it a name might be something to discuss, but this is pathology that we don't see in normals visually, and I think we have several different comparison cohorts that don't show this pathology. So I'm convinced, at least in this subgroup, that this pathology is real. It's not localized only to the airway, that there's vascular pathology and there's some abnormality in the parenchyma as well. I think how that explains the dyspnea, is still up for discussion. I think that's been really hard to understand. And over time, I will say that, at least on the VA side where I do my clinical practice, we don't typically biopsy these people unless we think there might be a different diagnosis, because there's really nothing that we can do treatment-wise if we find this diagnosis currently. So a lot of this has been done by Bob, who has seen a lot of patients that come from the Fort Campbell, Kentucky area, and he's done more biopsies than I have, and that's why we have this number to look at. But I think, to summarize that, I really think that this pathology is real. Does that mean that everybody who's ever been diagnosed with this has constricted bronchiolitis? Probably not. But now that we're getting numbers of 60, 70, 80 samples that we can look at, I think there's pretty consistent findings, again, in this group.
Follow up just one more step on that. The criteria for getting the biopsy, once the New England Journal paper came out, may have changed some. The question is, you say 1 or 2 or 3 patients a month. Are they all from a period of time of exposure or having been in the field that matches up, or is it still, are there new exposures that are occurring that you're seeing these people from?
So what I'll say about that is that the people who have gone to biopsy and the people that we're seeing are from the same theater of operations, but I'm not sure that we can limit it to one specific time. And those are the people that we have been evaluating. So not prior Gulf War or even before that folks. So I don't think that completely answers your question, but I don't know that there's a single time window in which we have a conserved exposure period that we can identify.
Let me make a comment. I'm well aware of the folks that went down to Vanderbilt. They were in the 101st in Fort Campbell. Early in 2003, many of them were stationed near a burning sulfur mine fire that was burning for about a month or so. So there were about 1,000 or so troops in and around that area. And the one thing that is unique about, I think, the early ones that he did was that they had that exposure to the sulfur mine fire, which is very different from the ongoing exposures, whether it be burn pit or sand. And there have been reports of a few chemical exposures here and there, but clearly this is some of his cohort was related to that big sulfur fire that burned in 2003.
So thank you. That's a really important point and is absolutely correct. But subsequently, there have been additional patients that, and we always have asked about those kinds of locations based on the initial group, and that does not seem to be as common as it was from that first set that was evaluated.
Let me make another comment while I'm up here. One of the reasons that we put together Stampede 1 and Stampede 3 is I didn't feel, not so much from a biopsy standpoint, but from a workup standpoint, there could have been a lot more things done prior to saying that they had unexplained dyspnea. So we've gone about, we published a paper in 2002 with a non-deployed group looking at exertional dyspnea and still found 25% with unexplained dyspnea. Didn't do any biopsies in that group. And what we tried to do was systematically do a more comprehensive evaluation before we considered doing anything in terms of considering that diagnosis or considering a biopsy in these cases. That was not done in a lot of the group. I know they had some CPETs. I know they had some methylcholine challenge testing. But at least the data that was presented in the article didn't suggest a more comprehensive evaluation.
So in that 25% of your population who were non-deployed and had exertional dyspnea, was there a diagnosis made?
No. I mean, we did not give them a specific diagnosis. So we basically took all comers coming to the clinic with this complaint of primarily exertional dyspnea and evaluated. Now, we didn't do all the same things that we've done this time with Stampede 3. I did not, at that time, and is not doing high-res CTs. I've sort of changed my practice now to do high-res CTs in everybody, although the number that are positive are fairly small. We also added bronchoscopy to it and doing BALs as well to look for potential biomarkers, inflammatory markers, and we're still evaluating that data to see what that says, what that shows.
This is just almost a random thought, but is it possible that all of these people deployed or not deployed came from some unique areas within the 48? I mean, instead of blaming Afghanistan, do we blame?
Hard to say. I mean, I think we brought up earlier the fact that, where would they get these other exposures? Well, the Army trains us at fights, and they take them down to the San Joaquin Valley, and they expose them all to the dust down there. If you've ever been to Fort Bliss,
that's
out in El Paso, right? So there are a lot of similar environments. The problem with most active duty guys, with most, on the exception, they move around a lot. And so we have people going to Korea, which we know is bad. We have people out at National Training Center, other environments. And so and the thing that popped in my head, the things they do on a regular basis, we have this nickname called medicanics. So when our medics are not doing stuff, they're taking care of vehicles. So they're doing a lot of jobs that may have exposures related to them, regardless of the field that they're in.
So it's a very different population where you may get a referral clinic for more dyspnea. I'm aware of one case personally that didn't appear to have a burn pit exposure. I know that based on our workshop that we did with ATS, Denver's had an experience with constrictive bronchiolitis, so it does appear to be in a couple of centers. It's being recognized, and so there appears to be a number of cases, that some of which are true cases, some of which may not be due to artifact, and the point is to try to learn from this and to understand where what are those exposures in those cases where it's unequivocal by biopsy that this is what's going on, relate that to the clinical, and get some follow-up on what this natural history is. And that's what I think is important.
No, I agree that part of the task of the committee is to try and look at moving our understanding of all of this forward, and as many steps as we take going forward, we'll have some going back, I'm sure. But there are some opportunities, there are some new technologies, and some of it is the next time round to make sure that we do the things to minimize risk and at the same time hopefully collect more information on exposures and so on. So this has been a really very interesting day.
Can I add one statement about the constrictive bronchiolitis?
You can.
So when we looked at the airborne hazards and open burn pit registry data, the rate of self-reported constrictive bronchiolitis, it's an option, it's an item to tell. I have, as a physician or other medical provider, ever told you have constrictive bronchiolitis. I haven't looked at the numbers recently, but we had about, I think it was 800 or 900 people out of 150,000 who self-reported that diagnosis. But when we bumped that up against ICD codes in the VA medical record that might capture constrictive bronchiolitis, there was actually very little overlap. And we also found some people who didn't self-report it, but we found a diagnosis code that might indicate that. So we are still exploring that, and part of what the Burn Pit Center of Excellence is doing is targeting those people who have self-reported it and then doing a manual chart review of their VA medical record to see what's been done in terms of workup, and then depending on where they are in the evaluation, we're bringing them in to be evaluated more completely.
And they've made that self-reported based on their symptoms?
No, it was has a physician or another medical provider ever told you had this condition?
And we haven't reported this, but we've looked through DOD records specifically for people with that diagnostic code. And I would say the majority of except for those that got seen at outside centers, like Vanderbilt, the majority of them had never even had a biopsy.
Yeah.
Or any other pulmonary. I think people were checking constrictive bronchitis or thought they were checking constrictive bronchitis, and they had checked it wrong.
It's a
within the chart.
tough diagnosis
Yeah.
for a clinician to make unless they have a lot of experience with the disease. But anyways, I want to thank everyone, the speakers, the committee, the participants. It's been a very, very interesting day. Thank you.